Okay. Can everyone hear me? Hello. Hi. I'm a bit short and I'm behind this monitor, so please forgive me. But other than that, hi, I'm Nayam Haihambo. Today's lecture will be in English, if you guys don't mind. And today we'll be talking a bit about psychopharmacology from a different context. So we're going to be looking at it in terms of Namibia and South Africa, which is very far away, I understand, but I promise there's a reason. But just to give you a little bit of an introduction, I'm currently a postdoc in social neuroscience, so I'm working on loneliness and conformity and the brain. So if anyone ever wants to participate, you're welcome to. We pay €100 and you get a brain scan. But other than that, before I moonlighted as a researcher, I was a clinical psychologist in both Namibia and South Africa. So I worked in acute populations at a psychiatric hospital. So I was looking at children and adults, and my main responsibility was in forensics. So I was a forensic expert, and I was looking at people with acute psychiatric presentations that may or may not have committed a crime. So based on that, I have some experiences that might be interesting for you. So we're going to be looking a bit at psychopharmacology in Namibia and South Africa, and maybe from you guys I can learn a bit about psychopharmacology in Germany. Does that sound okay? I'm seeing some heads nodding, so I'll just assume that everyone's okay with this. Okay, just to give you a brief outline, we're going to be looking a bit at the historical and cultural context, which helps us a bit in understanding why psychopharmacology is the way it is in Namibia and South Africa currently. We're going to be looking at the role of clinical psychologists, how it might be similar or different from Germany, in case any of you want to ever practice outside of Germany, potentially somewhere further south. I would recommend Namibia, since I am Namibian. We're going to be looking a bit at medication approval processes, which, fun fact, are quite similar to German ones, maybe a lot less rigorous. And then common psychiatric medications, differences in research interests. And then I'll tell you a bit about fun facts, and we might have a discussion about a case study. So that's the general overview. So starting with the historical and cultural contexts, there are four main eras that we're going to be looking at. First, pre-colonial, colonial era. Does anyone know about Namibian colonial history? Does anyone know who colonized Namibia? Yes. Yes, it is one of the few German colonies. Does anyone know who colonized South Africa? Sorry? Yes, up there. The Dutch and the English. And then South Africa then also colonized Namibia, which is what is then known as the apartheid era. And then we're going to go to modern day. So we're going to go through hundreds of years. Is the audio okay? Feels a bit echoey. Okay, so then we're going to start with pre-colonial era. What do you guys think psychopharmacology looked like there? If you can take any guesses. This is predating modern psychiatric. I see a hand up there. That's already quite a good summary. Did everyone hear her? Not so much, so I'll go over it. So she was saying there is not many medications, and potentially people with psychiatric illnesses were seen as special because they could see and hear things. So this is very much in line with a lot of other countries where predating psychiatric or modern medicine, where people took pills, we often relied on herbs and plants and often roots to treat illnesses. So oftentimes, when we saw someone that was psychotic or thought they were seeing things or believed that they were someone special, people did see them as special. So oftentimes you'll see someone that says, oh, they see their dead grandmother. In modern day psychiatry, you might say, your grandmother is not alive, she's not a physical being, so something might be wrong or there might be some kind of discrepancy there. However, in pre-colonial times in Namibia and South Africa, oftentimes these people were seen as special, and they would become kings or rulers of small colonies. And they would often be seen as leaders of households, because if you can see something that is not there, perhaps you're experiencing something that's beyond the physical, so something a little more spiritual. But there were some minor treatments for people that were experiencing what they called nerves, and that was oftentimes people who had depressive or anxious presentations, because they would then not be functioning the way that people needed them to function. So for example, if you needed someone to take care of the children, but they couldn't get out of bed, this was not necessarily helpful for the society, so they would try and treat these people. And oftentimes that was with remedies such as, I'll say the native ones because I cannot say the scientific words, so kana or kohut. Fun fact, kana is currently being researched. It is a mild psychedelic, so it has psychedelic properties, and it was given in a form of a tea. And if you see it down here, very pretty plant, smells like rotten flesh. They would give it to you as a tea, and oftentimes people would have a mild hallucinogenic effect, and it would sort of like make them a bit more lively. Another alternative was rooibos. I'm sure you've heard of the tea. You can get it in the shops right now. One of my favorite teas, by the way. And this is sort of comparable to, I would say, chamomile. So it had like these calming properties, and oftentimes this was given to mothers of young children or elders who were seen as being nervous, who couldn't get out of bed or seemed anxious about something. And this knowledge was often passed down from generation to generation, mostly through women. So, and much like ancient civilizations, a lot of these things were not written down. So it was based on spoken language. So I would tell you, or I'll tell my daughter that there's a certain kind of plant or root, and it is used for certain things, and there'd be like a catalog of things, like a mental Rolodex for what certain roots and plants did. And it was just basically passed down, and there would always be a healer in the family. There would always be a mother or head of the house that would take care of everyone else with this knowledge. Where are we? And then we come to the colonial era. So this was an interesting time for psychiatry. This was when people also started to sort of categorize what different illnesses were. This was 1800s. And people were trying to understand what it meant when people, for example, were hallucinating. This was in the West now. However, when it came to how it was practiced in this case in Southern Africa, this introduced something called ethnopsychiatry. And it was basically a way of trying to understand how people of color, or in this case, Black people, could, for example, express anger when they were agitated, but in a way that benefited the colonial masters now. So, for example, if someone was at their wit's end and ended up being aggressive, they would often then be labeled as having a psychiatric illness that then became convenient for the way that they were treated. And oftentimes this ethnopsychiatry was then practiced in underfunded, overcrowded asylums, which meant that this was often political prisoners, and it included torture to try and get these spirits out, or lobotomies to try and sedate people so they no longer try to rise up against the rulers. And this was then told to the general international public that they were treating aggressiveness in savages. This is also where a lot of modern-day psychiatric medications were tested. So it became a convenient sample to see whether or not certain medications resulted in severe side effects or even death. On the other side, there's also a practice where if someone had a genuine psychiatric presentation, so if they were genuinely hallucinating or had an ongoing presentation, so like a chronic psychiatric illness, they would often be forcefully sterilized because it is not convenient to have workers that are not able to have sound minds. So oftentimes then you'd see forceful sterilization, especially for breeding slaves. So you want to keep the population large, but you want to keep it healthy. So they weeded out people with not just physical, but also psychological illnesses. And in this time, knowledge of indigenous healing, such as the roots and the plants, was suppressed. So you could practice it, quote unquote, but you could not teach your children about it. This became illegal. And that had the consequence that grandmothers could not teach their daughters or their grandchildren. For example, sadly, my great-grandmother had all this knowledge. My grandmother knows a little bit because illegally she tried to learn, but my mother doesn't know, and I definitely don't know. And every now and then my grandmother will give me something, and I'll be like, I'm not sure if this is okay to drink, but I'll drink it anyway because I trust that she knows something that I don't know, and I've been fine so far. But essentially, this knowledge is no longer being passed down. There's a small generation of people that are now trying to go back and see, okay, what are these things that we're missing out on? Also because Namibia is diverse in terms of plants. It's one of the oldest deserts with a lot of roots, and we're trying to figure out what they all mean, but a lot of this knowledge that had existed in the past on what it treats has been lost. So we're trying sort of to go from ground zero to try and figure out, okay, what are we looking at and how are these roots beneficial to us now? So in the same vein, during the apartheid era, marginalized indigenous healing practices were not just, so now you couldn't teach it, but you also couldn't practice it. So it was illegal for you to go to a traditional healer, and it was illegal for your grandmother to give you something that is unnamed to try and help you. So teas and rooibos was okay because that was seen as accessible or okay. It was seen as a tea, but kana or kohut, for example, the psychedelics were no longer allowed. And people could be imprisoned and even killed. So this was not just traditional healers within the families, but also mother to daughter. You could not just try and heal your child's headache. And this was done using propaganda as well in schools that told you that so your mother is uneducated, what she's giving you is not healthy for you, and this is why a certain thing happened in your life, or this is why your child constantly has nosebleeds, for example. So they found all the negative things in your life and tried to convince you that it's because of these traditional healing practices that they exist. But this is also the time where psychotropic medications, as we know them today, were introduced. However, they were introduced in a very selective manner, which meant that highly sedative medications such as haloperidol were prescribed at unusually high doses to try and sedate populations, especially males. So people that could potentially cause an uprising, they were sedated. And again, people with psychiatric illnesses were often abducted, sterilized, and left to die in concentration camps. Now, if you think that this was happening hundreds of years ago, it is not the case. I was born into apartheid. This happened 30, 40 years ago. It is quite a recent history where this was still happening, where people were being sterilized when they were seen as unfit physically or psychologically. And this is also where there was a heavy reliance on ECT. Does anyone know what ECT is? I'm sure you've heard of it. electroconvulsive therapy. Any hands? Anyone wants to try and explain what it is? Yep. It does look brutal. It is in some cases still prescribed today. So basically it is an electric current that is passed through the brain, but it is high enough that people oftentimes need to be sedated to undergo it. In itself, the way that it is practiced today is not as harmful as it was back in the day. You also have other treatments such as TDCS or TMS that have a similar function. But back in the day, it was at much higher electrical doses, and oftentimes it would result in personality changes. So this became almost an experimental treatment for a lot of psychiatric illnesses, not just depression. Luckily, this has changed, but that is some of the sadder history that hopefully we never go back to. So now we get back to modern day, so post-1994, what that looked like. So after there were all these people that were being forcibly sterilized, over-medicated, sometimes their brains were being electrocuted, essentially. So after all of that, and also interestingly, some modern tests that we use now, for example, intelligence testing, a lot of those were pioneered by South African researchers who used it to try and explain why races needed to be segregated as well. But learning from some of that history, people then started prioritizing patient care, patient needs, and transparency and advocacy. So using this research to make sure that we use it for good and make sure no one is harmed. So there is a lot of effort to make sure that patients know what they're being treated for, and that we make language accessible enough that people can choose to have certain treatments or not. So I guess there is some benefits from a darker history in terms of psychiatric care in the past. There's also a growing recognition and value of traditional healing practices. So right now, for example, there are policies that are coming into play where traditional healers can register as practitioners, as community practitioners, so that people have a choice to go to a psychiatrist, a psychologist, and a traditional healer, or a combination of all of these. I'll tell you a bit later about certain specific diagnoses that might not be prevalent here, where a traditional healer might have to work with a psychologist, for example, to try and treat a certain kind of presentation. But in terms of the modern day era, psychopharmacology is also governed by strict regulations that define and authorize certain kind of medications, under what circumstances they're prescribed, and what is safe dosage and not. So even if, for example, ECT is still an approved treatment in Namibia, the dosage is much lower, to the point where there are very few side effects now. Modern day also introduced the fact that psychologists and psychiatrists have to meet rigorous, and I mean rigorous, educational training and licensing requirements, with a clear distinction between their roles and responsibilities. There was a time, for example, where psychiatrists could do therapy and psychologists could prescribe, so sort of the terms were interchangeable, but now this is no longer the case, and so the titles are governed by law. You cannot just call yourself a psychologist or a psychiatrist without meeting certain requirements. What's relevant for you is, what is a clinical psychologist? So essentially it's not very much different to here. You need a bachelor's degree, a master's degree, you need training, and then you register. So for example, when I was training, I had to have a 4-year bachelor's, which included an honors. And then I guess master's is where it becomes a lot more competitive in Namibia and South Africa, where most universities only take 6 people a year. So then you have quite a lot of competition, both nationally and internationally, because there's also a quota on how many national versus international people can be accepted. So you have a 2-year training during which you have to keep a roster of 8 patients per week, followed by an internship of 1 year and then community service of 2 years. So basically 3 years of training afterwards. Then after that, you need to do a board exam that allows you to be registered, and you have to maintain this registration yearly. It is expensive. Every year you have to pay a fee, but you also have to make sure that you have continuous development. So you have to follow classes on ethics, you have to follow classes on psychological training and theories and therapies, which I think might be the same as it is here. Yes or no? Anyone? Yes? Yes? It's similar, right? So the practices, I think internationally, with some minor exceptions, such as Belgium, for example, are generally the same. I was, for a short time, a psychologist in Belgium as well. There they seem to be a little more lenient in who can be a psychologist. For example, with your bachelor's, you can already start practicing. But that is outside of the scope of what we're talking about today. So a clinical psychologist, very similar to what a clinical psychologist is in Germany, and we're trained to provide psychotherapeutic interventions as well as assess and diagnose mental disorders. We work in hospitals, outpatient clinics, private practice, and oftentimes, or at least in the Namibian definition, it requires you to collaborate with other mental health professionals. So even if you're in your own private practice and you have a client that comes to you and you need information from a family, you cannot invite the family to your practice to get that information. You have to collaborate with a social worker who would then either go to the patient's house or your client's house, or even go to their village, so they can travel up to 10 hours to try and get you this information, because there's a lot of variation in how you treat someone and how you treat them ethically. I'm not saying that they're always treated ethically and this is always applied, but essentially the laws and policies are in place to make sure that we have individualized and ethical care for each individual patient. So we try and have comprehensive care as much as possible. So, why clinical psychologists need psychopharmacology? I'm guessing you are all required to have psychopharmacology to some extent, and that is for a number of reasons, right? So it helps us identify medication side effects and distinguish them from therapy outcomes. So if, for example, you have a patient comes to you, has, I don't know, a depressive disorder, started an antidepressant, but 6 months down the line, you realize that they're having less depressive symptoms, but they have increased suicidal ideation. If you know what kind of medication they're on, you might see this as a side effect, or you might think that, oh, things are still really bad. So you need psychopharmacology and at least some basic understanding so that when you look at your treatment outcomes, you're able to distinguish them as true outcomes versus side effects. And it's also a really good way for you to advocate for your clients. So oftentimes you might be able to see better than your psychiatrist that, for example, someone has a depressive disorder versus a bipolar presentation. Whereas, and if you know medications, for example, and you know that they're going to start them on a first-generation antidepressant, you know your client enough to know that this might, or they've had something that looked like a manic episode before, you know to tell the psychiatrist that antidepressant might cause a manic episode. So this is important for you to at least have some basic information on what you're looking at. So yes, internationally, psychologists need to know at least some basic form of psychopharmacology. And it also helps you with comprehensive case management. So you're going to support other healthcare professionals, and it also helps you with psychoeducation. So you don't just see your client, you see their families as well. And in order for them to understand what exactly they're signing off on, you need to be able to tell them what treatment options are, and you can only know that if you fully understand what some of the psychiatrists or the medical model might be accessible to them as well. There's a true ethical responsibility, so that not only your psychiatrist tells you, okay, these are the options, but you can sometimes also, if they don't have time to have a full comprehensive view, to tell them that yes or no, something is possible or not. Because you have a responsibility to advocate for your client. A lot of people don't because they may be scared. The psychiatrist might seem like they know better than you, but oftentimes you spend a lot more time with your client than they do. So you have a responsibility to advocate for your clients as well. And one of the ways to advocate in a bigger form, so not just patient to patient or on a single patient or single case basis, but you can also be part of certain boards, such as the medical approval process, which is essentially a lot of people think that, okay, this is something that happens on a policy level, or this is something that doctors on a board do, but oftentimes psychologists in Namibia are also required to be part of treatment approval processes for psychiatric medications as well. The approval process is similar internationally. So Namibia follows WHO guidelines, and all of this is governed by essentially the same board. Namibia and South Africa, as much as we want to say that we are separate, and to a large extent we are, we follow very similar policies. So we call our regulatory boards different names, but essentially they do the same thing. So what happens is oftentimes internationally, because we don't have our own large pharmaceutical companies, oftentimes these are either Belgian, German, or American, sometimes British. So these companies will apply for approval for a certain medication. And this is not just new medications, this is old medications that are on the market already. So they have to apply for approval for it to be disseminated in Namibia specifically, or South Africa specifically. They're then assessed for whether or not they're cost effective, and unfortunately, cost becomes a really, really important factor in the approval process for one very big reason. Southern Africa doesn't have that much money. So you need governments to be able to afford to import these medications, but you also need your patients to be able to afford to buy those medications. So oftentimes more modern medications are put through the approval process, but they're not then approved because they're too expensive for the market to be able to afford. Basically the approval process looks at affordability, then you go for like safety and dosage. Luckily, oftentimes things that are currently on the market have already met some international standards before they are then also introduced in South African and Namibian markets for approval. They also look at efficacy and side effects, and then monitoring and reactions. And even if they are approved, they continue to be monitored down the line again to say, okay, let's say, for example, your approval process takes 3 years to go through phase 1, 2, and 3. It still is then monitored later on because you never know, because side effects might start appearing after 10 years, for example, or the side effects might happen on a reproductive level. So these continue to be monitored. And it also, during this monitoring process, we also make sure that medications are cost effective for the population. So you put it on the market, and then based on dosage for that specific population, you realize that okay, for us, what was approved was one pill. However, we find that in our population, oftentimes people need a higher dosage, so 2 pills. So this goes through the process again, but then this also means that medications become double as expensive. And we need to figure out whether or not the government will then sponsor people for half of the other amount. So this is important for the approval process, and this is also where you come into play to start advocating for certain medications, because if you know enough about your psychopharmacology, for example, you know that certain kinds of medications have really, really bad side effects, whereas some other ones that might be more expensive have less side effects. So as a psychologist, your work is then to make sure that policymakers, government agencies understand that even if it is more expensive, your client base or your patients need this more expensive medication because it is basically more ethical, because it has less side effects, even if it's more expensive. In terms of medications that are currently on the market, so that I can give you an example of what I mean by cost-effective versus bad side effects, there are 3 classes of medications that are currently available. So if I tell you about first, second, and third generation, I'll do this. First, second, and third generation psychotropic medications, does anyone understand what I mean by that? Is this something that has come up in your lectures before? Can I get a head shake or a nod? No? Okay. So psychiatric medications, usually for psychotic or bipolar presentations, are classified internationally into 3 generations. So first generation is older, and third generation is newer medications. So in terms of first generation medications, these are what are described as typical antipsychotic medications. And these are usually your haloperidol or clopramazine, for example, and these usually affect positive symptoms of schizophrenia. So for example, they affect hallucinations and delusions. Oftentimes, if you're in a psychiatric hospital, oftentimes if someone doesn't respond to newer medication, then there's a huge debate on whether or not you should give them a first-generation antipsychotic and how you're going to monitor them. These have really, really bad side effects, and the side effects occur a lot more commonly than newer medications. These first-generation medications are oftentimes for severe psychotic presentations, so schizophrenia, and oftentimes when a schizophrenic patient is agitated or aggressive. But there are a lot of extrapyramidal side effects, and some of the extrapyramidal side effects would be, for example, tardive dyskinesia. Does that ring a bell to you? Sort of. Okay, so it's sort of like a movement side effect from a lot of antipsychotics, a lot of first-generation antipsychotics. But then it's also just physically uncomfortable for some people. So for example, you might experience like a dry mouth or constipation. Fun fact, when I was still a young psychologist, and I do not recommend that any of you do this, by the way, I was curious because a lot of my patients would tell me about some of these extrapyramidal side effects. And I had read up that if you do not have a psychiatric illness and you take one of these first-generation medications, you would experience these side effects within a day. You can imagine where this is going. So one day, a couple of friends and I decided that we were going to essentially steal a few of these first generations. So we basically saw clopramazine, and we locked ourselves in one of the rooms close to the on-call rooms for the psychiatrists. We didn't tell them, we just said, if we call, please answer. Because we wanted to find out what it actually meant when our patients were telling us that they have this heavy feeling of a blanket over them, or they had a dry mouth. because it's difficult to imagine something that you haven't experienced, right? So we took these medications, and I would just say don't try it. It is extremely uncomfortable. It builds empathy, yes, because you truly understand what it feels like to have almost like a 20-kilo blanket over your shoulders when you take this medication. But the side effects for first-generation antipsychotics or psychotropics are extremely uncomfortable. But please do not try what we tried. Let that just be enough that I told this story. And then we get to second-generation psychotropics. These are atypical antipsychotics and have a broader receptive activity. So they target both dopamine and serotonin, and they're used not just for schizophrenic presentations, but then we also get to mood disorders, because it then also helps alleviate some of the mood symptoms. So it's they act as stabilizers or mood stabilizers. The side effects compared to first generation are quite mild. Most of them include, for example, metabolic syndrome or weight gain, and it does put you at a risk of diabetes. Oftentimes, also because statistically a lot of women tend to be diagnosed with bipolar disorder, a lot of them would then start to, and disproportionately, a lot of women suffer from the side effects of weight gain from these second-generation psychotropics. A lot of people stop the medication because they don't want to gain the weight. But I would say that weight gain is a lot more mild than tardive dyskinesia, where you lose control of your muscles. But as a response to people putting down medication because some of these metabolic side effects, we then have the third generation psychotropics, the more modern medications, which are what is mostly available here in German hospitals. And these are typically enhanced serotonin and dopamine balance, and they are developed specifically to minimize these side effects. But the thing is, they are mostly for treatment-resistant depressive disorders and psychiatric disorders, not so much for bipolar presentations. So the one thing that they tried to target, which was the weight gain, that was not the population they were able to reach. But essentially, these third-generation medications have lower risk of extrapyramidal side effects. And some of the side effects that they do have include fatigue, headaches, and just some mild metabolic effects. So some constipation, but you're not having sort of like irritable bowel syndrome type presentations anymore. Because of costs, oftentimes Namibia only has available first and second generation medications with the higher side effects. And it's only recently with some government support that third generation medications are then becoming available, but they're not largely available, is what I'm trying to say. And in terms of specific medications, that are commonly available. In terms of antidepressants, you have fluoxetine or Prozac, sertraline, citalopram. So it's a lot of things that you would potentially also hear around here as well, but with a lot less variability, also a lot less generics. These antidepressants do make sense to you, right? You've heard of amitriptyline, for example? Perfect. And these are oftentimes within the second or third generation medications with just some side effects like nausea, headache, drowsiness. And then you have anti-anxiety medications, diazepam, lorazepam. These do ring a bell? Yay. Okay, so we're all having the same medications. Side effects include drowsiness, some mild cognitive impairment, and then we have the antipsychotics. For us, that is where the first generation medications come into play with the severe side effects. So haloperidol also largely dispensed here, but to a lesser degree, and also at much less doses here. Risperidone, clozapine, makes sense? Sound familiar? We also have a lot of lithium. But as you can imagine, a lot of the third generation medications require you to monitor them a lot. So you need blood work, you need to go to your doctor quite frequently. The problem is, however, Namibia is a really, really big country. It's 4 times the size of Germany. And we have a really, really small population. So we have about like 2.5 million people. So as you can imagine, we have the problem of having way too much space. Your patients are very far away from the hospitals. Oh, this thing is annoyingly echoey. Okay. So you have your patients that are really far away from their doctors, which means that they have to travel sometimes 10 hours to see their psychiatrist. To put into perspective, Namibia has 2 psychiatric hospitals, and the largest one is completely in the center. And in order for you to go from one extreme of the country to the other, that requires about 10 to 12 hours of driving. So oftentimes the solution is to give people longer acting injectables, so they only have to see you once a month or every 2 months, but they go without monitoring, so you have to give them low doses. So oftentimes you find that your patients still tend to have some of the primary symptoms that they came to you for. It just eradicates some of them, but not very much of them. Yeah, so we have these injectables, but it's still not the ideal situation. So oftentimes we then dispense psychologists and social workers to the villages to see whether or not there's anyone in the population that they could teach some of this information. That is acting or working a little bit okay currently. But this is also where the traditional healers come into play, because they then do like longer trainings in order to help monitor some of these side effects. They don't prescribe, but they can help us monitor sort of at the population level what everything is looking like. Some of these presentations and the medications and sort of the pitfalls that we observe in the population also inform the kind of research that we do. Before we go there, what do you think are Germany's main research focuses currently? In terms of psychiatric medications or psychopharmacological research. Any guesses? Yes? Mm-hmm. About what? Depression. About depression. Mm-hmm. Anything else, specifically maybe in terms of pharmacology for depression? No? I'll give you a bit of an idea. So a lot of research currently is looking at ketamine, rapid-acting antidepressants, because depression is one of the leading causes for psychiatric admissions in Germany. So there is a lot of focus on depression and also anxiety-related disorders, because there's a huge overlap. So ketamine research, partly because ketamine has been found to work really quickly within hours compared to traditional antidepressants. And there is a lot of active research in this field. And it also, interestingly, ketamine is found to have neuro or plasticity-related effects on the brain, which is then driving a lot of the research currently, not just in Germany, but the general West. Then Sort of in the same vein, you also find psychedelic-assisted therapy. So here you're looking at like psilocybin or MDMA-assisted therapies. So there's a lot of research focus on that. I think recently there was approval on stage 3 therapies. So a lot of this research for MDMA and psychedelics is at a policy level, looking at how it might be dispensed in the general public or in hospitals as well. There's also long-acting injectables to see whether or not patients can more independently help manage their own symptoms. Dementia pharmacology. Germany has a very large aging population, and aging does come with memory-related effects. This is also related to loneliness. So dementia and memory research is on the rise currently. And then there's also large-scale pharmacological data sets that are being assessed. We're not going to be looking at the ethics of it specifically, but Germany has one of the biggest databases looking at, for example, what are they called? Insurance. So if you have health insurance, oftentimes they can pick your data to see, for example, where are the claims coming up from mostly, or what are people mostly hospitalized for. And this is something that is different to a lot of other countries, let alone Namibia. So oftentimes this information or such data sets just don't exist. They're just not, those infrastructures are not available. But here, when you compare the research that is popular in Germany versus the research that's popular in Namibia, you see that there's a marked difference. So for example, we're looking at sort of like ground zero. How do we integrate professional standards in research? How do we start to research at hospital levels, for example, looking at statistics for even just patient admissions or prevalence of certain kind of symptoms or presentations. That is what is currently being researched now. For reasons, for example, if Germany's admissions are mostly around depression, South Africa and Namibia mostly have substance-induced psychosis. So for South Africa, it's usually something called TIC, which is methamphetamine, and Namibia is alcohol-induced psychosis. This is for a number of reasons as well. Alcohol is great medication for people that want to feel alive when they don't feel so much alive. And given the historical or very recent historical context, a lot of people turn to alcohol or drugs, and the resulting psychotic symptoms are what usually gets people into hospitals. Then there's also a huge HIV pandemic. So you have a lot of people with HIV-associated neuropsychiatric complications. A little known fact is that HIV, especially when it is progressed to later stages, results in people hallucinating and having like psychotic type or psychotic looking symptoms. So people sort of want to see how this happens at the core, or whether or not this is results from treating HIV, because some of the side effects for ARVs or from ARVs, especially the typical ones, is that it causes psychotic presentations, especially in children. So children born from mothers who are positive, the ones that remain positive, oftentimes if they are treated, they then later on tend to develop a psychotic type presentation. So this is also a huge research field. And then what I find particularly interesting is gene variation in how a lot of psychiatric medications or the enzymes that respond to psychiatric medications, how those are metabolized. I'll give you a little more information on this specifically, but we're looking at CYP450 enzymes. Have you heard of these before? Perfect. So those enzymes have a huge genetic variation, and given that there is huge genetic variation in Namibia and South Africa, psychiatric medication does not respond the same between people, between families. So a lot of research goes on to this. And then also community psychopharmacology, especially in low income or low resource communities. So if your doctors are not close to your patients, it's easier to teach other people in the community to recognize mental health disorders, side effects, or when someone just basically needs help. So there's a lot of research to see how do you treat or how do you teach people so that they can recognize some of these things. But also, who do you teach? Do you teach parents? Do you teach teachers? Do you teach, I don't know, the king of a small village? So there's a lot of research on sort of like what kind of therapies they can learn at like minor intervention levels versus how do you psychoeducate or monitor or even teach them, for example, to draw blood so that if someone is, for example, taking lithium, so that they can continue to be monitored without suffering toxicity. We're on the same page so far? Great, I'm happy. So if we're looking specifically at CYP450 enzymes, the research on this is particularly exciting. Why? Because if you're looking at the gene expression of these, so if you're looking at a CYP2D6 and CYPC19, there's a lot of genetic variation in how it is expressed. So, okay, how much do you know about these enzymes? You know a bit about it, how it metabolizes medication? Nodding. Okay. So these enzymes sort of are responsible for metabolizing almost like 70 to 80% of the medications that we take, or psychiatric medications, and they're usually found in the liver. Is that new information for anyone? Yes? Mm-hmm. Mm-hmm. Yes, so we're basically looking at it in that direction. So basically, essentially sort of like what you're looking at, there are 4 types of ways or 4 types of metabolizers. There are people that essentially metabolize it super quickly. And so, for example, these people might need higher doses, for example. And you have poor metabolizers who are really, really slow at metabolizing them, and oftentimes they result in toxicity. So even if you give them a relatively low dose, sometimes they then still experience toxicity because it takes too long for the body to process it. Then you have normal metabolizers and sort of people that are in between as well. So you have like 4 levels in total. The more extreme cases or the more concerning ones are the poor and the ultra quick metabolizers. You had your hand up again? Mm-hmm. Mm-hmm. Not necessarily. So the research on the side effects is relatively new. So basically the question was, these ultra-fast metabolizers, would they then also have more side effects? The research on this is a bit marred because there are people that will metabolize really quickly and then have side effects later on. But then there's also a general notion that if it is not in your body long enough for it to cause any kind of disruption, then you might not have very many side effects. There is not much information to really tell us what happens on which end in terms of side effects. a lot of the research on this has to do with like immediate effects. So the reason why this research is particularly interesting is in Germany, for example, where you have a lot less variance in the types of, so in Germany, most of the time you find normal metabolizers. This is not to say they're not extremes. In Namibia and South Africa, given the genetic variability, you find a lot more people on the extremes. So you find a lot of poor metabolizers and a lot of ultra-high metabolizers. And where you'd find, for example, 2 to 5% poor metabolizers in Germany, you find about 20% in South Africa and Namibia. And as you can imagine, that causes a lot of problems in terms of trying to regulate or finding psychiatric medications that work for the entire population in general, or having policies to say a certain kind of dosage is recommended for our population or certain kinds of populations. So there are a lot of universities, both in Namibia and South Africa, that are trying to look at it at ethnic group levels. Ethnic group levels, we're not talking about like black and white, for example. Oftentimes you find that ethnic groups are segregated or differentiated based on language. For example, Namibia, 2.5 million people, we have 13 languages. Those are 13 different ethnic groups. So in order for us to be able to see, okay, what kind of variants or metabolizers we have, we really need to look at it in terms of language groups. So that's what is currently happening. South Africa has over 30 languages. We'll not even begin that. But essentially, there's a lot of variability. And within the country, within kilometers of each other, you find ultra-high and poor metabolizers, which is unheard of in the rest of the world. And this becomes then a problem, or an interesting problem, in terms of psychopharmacological research further south. So, for example, a Xhosa person and an Khoisan person and a Zulu person and a Sotho person, all living within the same 100 kilometers of each other, have very different ways of metabolizing, because their genes or the enzymes, the way that they're expressed and metabolized, is completely different, and we're not necessarily certain why. Is it because of Bantu migration, where people came from really different areas and then settled, but then these gene expressions continued? Is it because of diet? Is like, on what level does it occur? We don't know, but I think this is a really interesting research line. But then this also, it has the potential problem that because psychopharmacological research is very underfunded, that we cannot rely on German standards, for example, or European standards to try and inform dosage or medications in South Africa and Namibia, which makes it quite difficult for treatment down the line. So this is an interesting little tidbit on the research growth in terms of the CYP 450. Okay, now we're going to go to some other interesting facts, and this part only works if you try and work with me as well. So I have a couple of questions, if this decides to work. In terms of population, how many psychiatrists does Germany have? I don't mean absolute numbers. Let's say for every 100,000 people, how many psychiatrists do you think are in Germany versus Namibia and South Africa? Ballpark figure. Any guesses? 5 per 100,000? 6? 7? Tell me to stop. Yes? It's actually much less in both. Even if Germany has one of the highest densities in terms of psychiatrists, we're not even talking about psychologists, we're just talking about psychiatrists. So in terms of people that can actually prescribe these medications. Anybody? If I say lower, how much lower do you think we're going? Yes, we have 2. Yeah? $10,000 per 100,000? Twice less? Mm-hmm. Yes? 12 in Germany? You're closer? Namibia? Yeah. Yes, less than 2. So the numbers are shocking. Germany has about 13.2 per 100,000. South Africa has 1.5 per 100,000. And Namibia has 0.37. To put it into perspective, I know most of the psychiatrists in Namibia. They're less than 20. Shockingly little. So then this informs psychopharmacology because oftentimes medication is then prescribed by medical doctors who don't necessarily have an understanding of psychiatric illness. But shockingly little. Even for Germany, I thought like when people were saying, oh, there's a huge density of psychiatrists, I was also thinking like 100, 200 per 100,000. But it's 13. Okay. Why do you think there's such large genetic variability in Namibia and South Africa compared to Germany, for example? And this is including globalization. This is including people that migrate. Why is there such genetic variability? We have 2. You can battle it out. We have 3. Fight. Mm-hmm. 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 Back there? Mm-hmm. Yeah. Mm-hmm. There was a third hand. What they said, okay. So a lot of it does have to do with migration. So anatomically modern people or human beings originated in Africa, so Central Africa. And so a lot of these populations in Namibia are much closer to where humans originated, whereas German populations originate or are a result of much more recent migration. And even when we look at it in terms of modern migration, so in terms of globalization, there is a lot more, a lot less variation in Germany because people from Germany, for example, have children with people outside. You'd think that creates a lot more variability, but it doesn't. It results in a lot of the same gene expression being repeated over and over again, which in some senses is a lot better for civilization. That's debatable, but it does result in a lot less variation. Whereas people who are in the south, because everyone is so far away, you sort of just keep in your group, and then these groups remain distinct. They remain. It then continues to be a lot less variability because there's then not mixing of genes. So then it continues to be a lot of genetic variance even in these important enzymes. And then that causes a problem in terms of psychiatric medication. What do you think are the most prevalent reasons for being admitted in Germany, Namibia, South Africa. We talked about this a little bit already. Yeah. Mm-hmm. Mm-hmm. Yes. So, yes. Mm-hmm. That's true. So Germany has a lot of admissions related to depression, but because here there's also a lot of treatment that's happening outside of institutions, oftentimes people are then admitted because of suicidal ideation, self-harm, or harm to others, whereas in South Africa and Namibia, South Africa being methamphetamine-induced psychosis, and Namibia has alcohol-induced psychosis, mostly because of accessibility. South Africa produces methamphetamine for some reason, and Namibia has a lot of alcohol. Fun fact, Namibia has an award-winning beer which follows German purity standards. If anyone wants to try it, go ahead. I'm personally not a beer drinker, but I heard it's good. Just please do not end up in a hospital because of it. So yes, those are the main ones. Something that happens in every culture, sort of, but sort of presents differently, something called culture-bound syndrome. It has a very specific way of treating it. Does anyone have an idea of what culture-bound syndrome might be? Has anyone heard of it? Yes?
I'm not quite sure, but one example could be, I think, South and Southeast Asia. There are a lot of cases where people have psychotic symptoms due to a mutation,
Mm-hmm.
which is like a really rare case here in Europe.
Mm-hmm. So a psychiatric illness resulting from mutation. Meditation. Mm-hmm.
Not just in general, mental disorders, but psychotic symptoms.
Yeah, sort of like psychotic symptoms that are culture specific. Anyone else have an idea? A guess of what it might be? Yes? Superstitions? Mm-hmm. Sort of like a culturally relevant presentation that is maybe specific to a certain kind of population or seen as normal or not normal in a certain population, which might be seen as normal or quote-unquote not normal in another. Mm-hmm. Anyone else has a guess? Does Germany have something that resembles a culture-specific or culture-bound syndrome? I don't know this, I'm genuinely curious. Yes?
Maybe German Angst.
German what?
German Angst.
German Angst. What is German Angst?
It's like other countries see the Germans that they are really anxious.
Mm-hmm.
Anxious culture.
Yeah.
So the term German Angst has established in, I think, in America.
Yeah. Mm-hmm. So a lot of times culture-bound syndrome can also stem from sort of like a stereotype or like something that a certain group of people might express, but the rest of the world might see as like pathological, whereas that population might seem as completely fine. So there's a very specific presentation of culture-bound syndrome in South Africa and Namibia. So locally it's called amafufunyana. So basically, it's a state of sort of like a ritualized possession. And oftentimes people think this is then your calling to become a traditional healer. So people then start seeing their ancestors or thinking they're part of the ancestors and being extremely anxious during this time. And oftentimes they'd also have like convulsions, so like they'd have like these noticeable like body atypical movements. And oftentimes, if you come from the outside and never recognize this, you think that someone has schizophrenia, because it ticks all of the relevant markers, all of the relevant symptoms. The first time I experienced amafufunyana was not even in Namibia, it was in South Africa. I didn't speak the language, and someone was brought in by a group of friends, and they were like, no, he's seeing his ancestors, he's being called, he wants to jump off cliffs because he thinks his ancestors are there. So he was admitted for 3 days, and I, not knowing much, and a psychiatrist who was also not from the region, we started like observing, because you don't just go into treatment, right? We started observing what is actually going on. And when we sent a social worker to find his family, they sent a court order that we had to release him because we thought he was a harm to himself. So we admitted him. They went to court and basically vetoed this decision. He had to go home. We had to release him. And that's the first time I found out about culture-bound syndrome. His family believed that this was him being called to be a traditional healer, and he had to answer to this calling in order for him to be freed from these symptoms. So in order for him to stop having these psychiatric-like symptoms, he had to either deny this part of himself and then also leave the family, or he had to accept it and then become a traditional healer. I thought, definitely not. They'll bring him back in a couple of weeks. And sure enough, he's a traditional healer and he's fine. So some of the things that we thought were problematic or looked like a psychiatric presentation turned out to be this undefined cultural or culture-bound syndrome. And this brings us back to sort of the crux of it, right? What is a psychiatric disorder? So oftentimes disorder is like disruption or dysfunction in the way that someone works or behaves. But in order for us to see that it's a disruption, it's not something that I can define, right? It is defined by a society. It's defined by a specific community. And if that population sees it as something that is not disruptive, they don't see it as something that is quote unquote abnormal, we cannot go in and define it as such. So now there is a term called culture-bound syndrome that sort of protects these presentations across cultures, where you can recognize that certain presentations are as a result of a certain kind of outcome or a certain kind of calling that is culture-specific and is not necessarily a psychiatric disorder. Now you might be asking, but they could be wrong, right? So not everyone that has this calling is necessarily not psychotic. How do you make sure that you're right? Anyone has guesses? What would you do? You're working at a psychiatric hospital? Yes, we have a hand there. Wait and observe more. Would you release them? So you don't have access to their family, for example. So they're at your hospital. They continue to have these symptoms after 2 weeks. What happens? Do you treat them? Another interesting fact is they don't respond to medication. So you're giving them antipsychotics, but they're not responding. So then it becomes like this really weird thing, like your hands are tied with a certain thing, but you're not sure how to continue. So oftentimes then it becomes sort of like you need to figure out, or you need to understand cultural and societal norms for where you are. So if you don't have access to family, ask community members around, is this something that you've seen? Is this something that's seen as quote unquote normal? And there are things even in Germany that you might think is completely part of your day-to-day, whereas if I take that same presentation to my village in Namibia, it would be seen as extremely extraordinary. For example, and this is something that came up recently. I was telling my grandmother about eating rituals or eating habits in Germany, and that a lot of people were vegan. They don't eat meat, and they don't eat meat product. And not just my grandmother, my aunts, they saw this as something that is extraordinary. And if you ask a psychiatrist, they would call it a pick-eating disorder. It is seen as something that we just don't do. Whereas in Germany, it's seen as completely normal. So there is some things that if you take it out of the context where it currently is, out of the culture, it is seen as pathological as well. So if someone came here and they're like, my ancestors are calling me to be a traditional healer, you would be like, no, like this is not a thing. If you take them to South Africa, to a specific location, people will be like, yeah, he's the 10th one today. Whereas here, someone can choose not to eat meat, and you'll be like, yep, that's completely fine. You take them to Nkurenkuru in Namibia, and they'll be like, no, that is not a way of being. It is not a societal or cultural norm. So we need to understand the norms and cultures where we are. And sometimes we also just need to be okay with the fact that we might be wrong. We need more information. And also push the boundaries a bit. I'm not saying overstep people's boundaries, but ask enough questions to make sure that they also understand that they could be wrong. Because you do find sometimes where people think that someone is being called to be a traditional healer, but then it turns out to be grandiose delusions, for example. So oftentimes it's information that you have to share with them and they share with you. And this is also where traditional healers come into play. Yes? Mm-hmm. They perceive themselves as uncomfortable. Suffering is a difficult definition, but they do perceive themselves as being uncomfortable, feeling anxious, or being concerned about what they're seeing, especially when you're looking at younger people. Who know what psychotic disorder is, for example, if they've seen it somewhere around, they know what it means, then you'd find someone is quite concerned for themselves.
And you just described the scenario that which work in a hospital and somebody which come in with these symptoms.
Mm-hmm.
But would it be normal to curious that people in this situation go to the hospital?
It could be, especially if you see like a young person. They might come to you because they're like, my grandmother is telling me something, but I know that I have a cousin, for example, that has had a psychiatric episode before, and I don't know which one it is. So sometimes people come for treatment, sometimes they come for information, and that is also where we bring in traditional healers, because they then have a lot more information on what is culturally relevant or culturally perceived as okay within their own culture. Even within Namibia, there are about like 5-6 cultural groups that I would not be able to tell you what is culturally relevant for them. So it's sort of like a give and take. If I had such a presentation, for example, and I was being called to be a traditional healer, I would personally be scared. Yeah. Okay, so this is an interesting tidbit. There is some research on culture-bound syndrome, so Google Scholar might be a place to go. Yes? In South Africa. Mm-hmm. This is a really good question. The number of traditional healers is currently not known because we're limited by the people that do register. And you can become a traditional healer by your own right, but you can also become a traditional healer by calling. And you do have a lot of people that do practice as traditional healers, but they're not registered. So the true number of traditional healers, I'm not sure. This is not published. And I'm not sure whether or not they're planning to, but would be an interesting number to know. Okay. Okay, we're going to run through the next part because we have about 10 minutes. Why you need to know psychopharmacology about different countries, globalization. Because I'm here, and the chances that someone with a psychiatric disorder from Namibia comes here is not it's not unheard of. So let's say, for example, you're working at a hospital, and you're presented with Mr. A. He's 45 years old, he's from Namibia, recently moved to Germany. His friends brought him because he's having strange movements, presenting with involuntary actions. He seems agitated and restless. He's having repetitive facial movements, such as grimacing and blinking rapidly. He's got jerky arm movements. He's not sitting still. Again, this restlessness, and he's previously been received treatment in Namibia for hearing voices, but he's currently mute, agitated, and difficult to interview, so you don't have a comprehensive history from him personally. What are you going to do? The psychiatrists want to give him medication. They want to give him medication right now. You're a psychologist. Yes. You can ask the friends. What if the friends just met him? What you gonna do? This could happen. Genuinely. Yes. Mm-hmm. 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 Yeah. Take a second, try and ask simpler questions. That's a good strategy. Ask his friends if they know something. That's also a good strategy. What else could you do? You've sat in on this lecture. You remember, maybe not me, but you remember some of the slides. What are you going to do? For example, you remember that Namibia uses a lot of first-generation antipsychotics. He's got these jerky movements. It doesn't sound like a psychotic disorder. It sounds like an extrapyramidal side effect. Sounds like tardive dyskinesia, right? Sometimes you don't have information, but context matters. You might not be right, but it's at least something to give the psychiatrist to be like, wait, this guy was treated in Namibia before. Maybe we should query side effects. We don't have information on whether or not he's hearing voices. Why are we putting him on antipsychotics? And in the meantime, you can do more tests. There are tests to look for tardive dyskinesia and whether or not this is a symptom of, or at least a side effect of medication, or a primary presentation. Do those tests. And you also know that if, for example, he comes from a small area, you can look at his passport. You can find the area which he lives in. Is it close or far from a hospital? If he's far from a hospital, maybe he was on a high-dose injectable. Again, points you to tardive dyskinesia. And then you also want to at least let the psychiatrist know about these CYP, 2D6 and other gene mutations within that population, so that at least they are careful about the medications that they're going to prescribe, right? So take enough history, observe, be curious about where he comes from and the practices for psychopharmacological distribution before you make things worse. So cultural competencies are important. It's not just a lecture that you have once a year. It actually matters. So you might not remember everything I say. You might lose some of these slides, but at least let it make you a bit curious about who's sitting in front of you so that you're actually treating them ethically. In the same way that you'd want to be treated, right? If you end up in Namibia and the only information they have is that you don't eat meat, you would hope that they're not going to take you to a psychiatric hospital, right? So be curious. And that is all for today. Your slides are, I think, up on Moodle. And I will also give, because these are updated ones, different from the ones that are online, I will make sure that they are then also uploaded. Does anyone have questions? I think we have like 2 minutes. Anyone have questions, curiosities? Anyone wants to practice out of Germany? I'm curious. So everyone here is going to practice in Germany? Yes? No clue. Fingers crossed. Maybe Namibia. I'm just saying, we don't have that many psychiatrists, but we also don't have that many psychologists. So if you ever want to practice somewhere and you're curious, think about us. But that is it from me today. And thank you so much for participating and being curious.